we had to litigate, went to court on an urgent basis over a weekend, in fact, and argued and were successful in arguing that the 20th week means 20 weeks and 6 days. And if somebody complies with the other requirements to access an abortion, they must be able to access it up to 20 weeks and 6 days. And she was able to access that abortion. The court ruled in our favor. She was able to access the abortion and she was able to return to school.
Hello, I'm Françoise with the famous podcast, and today we're going to be speaking to Sasha Stevenson from South Africa, the Executive Director of Section 27, who's going to speak to us about how she and her organization use strategic litigation and grassroots mobilization to advance health and education in South Africa. I'm excited. So welcome to the famous podcast, Sasha. Hi.
Thank you, Françoise.
Yeah, you're in Joburg at the moment, right? In your offices.
That's right. I'm in Joburg on a very sunny, beautiful winter's day.
Oh, yeah. And here we are in North America on a sunny summer day. So I wanted to talk to you about the work of Section 27 because we're really in a very tough time right now around the world, and it can be, I think, easy to get very discouraged about the prospect of advancing access to health, to justice, of course, to human rights, but to healthcare and education in particular. And the work of Section 27 should be better known. I think it's very interesting to see how Section 27 uses litigation and mobilization, grassroots mobilization, to push for systemic change in the health and education sectors in South Africa. And so today we'll speak together about this particular topic, which feels so important and so urgent. What if we could all claim access to health and to education as human rights, rather than privileges or entitlements or only something you can afford if you're wealthy? And South Africa is a country where that has been the dream, right, and the vision, and where it's possible to think of health and education in those terms, because you have a constitution that was adopted in 1994 after the liberation from apartheid that includes the rights to health and education, which isn't the case with many constitutions, certainly not in the US, but not even in Canada, where I grew up, is the right to health or education enshrined in our Bill of Rights or Constitution. So Section 27 has been on the case since that time, or even before that time, because even when, as we know, when a right is in a constitution, it doesn't mean it's just going to happen, that the government is just going to roll over and make it available. So there are lots of challenges, and there was a need to push the government to meet their constitutional obligations in South Africa and to advance those rights in the years after liberation. That's where Section 27 comes in. So can you tell us about the origins of the organization? Like, how did it come about? What was the key issue that mobilized lawyers in South Africa to really push for these rights?
Absolutely. Well, I think, as you correctly identify, one of the great advantages we have in South Africa is our constitution that says everyone has a right of access to healthcare services, including reproductive health services, notably. That is written into the constitution. And that's, of course, it's not by chance. This is a product of the work of feminists and rights activists over many years. But we have that right in the Constitution. It says everyone. It's not just for citizens. So again, we have this expansive right. We also have in the same right, the right of access to healthcare services and reproductive health. It includes the right to sufficient food, to water, to social security. We have a right to education. So we really have a very good groundwork for use of the law and of human rights to make people's lives appreciably better. And of course, we're a country in which that was needed desperately at the end of apartheid and unfortunately continues to be needed. So Section 27 started as the AIDS Law Project. We started 32 years ago, within a year of the Treatment Action Campaign, which is our closest ally. And that was in sort of the early 90s. And at that point, we were looking to use the law and the new constitution to respond to the needs of people living with HIV, because we already had a significant HIV epidemic in the country. Mm-hmm. And so the early work of the AIDS Law Project, as it was at the time, was based really on stigma and discrimination. It was working for domestic workers who are almost 100% women who were being fired on the basis of living with HIV, for teachers who were having the same experience, for people who were looking for insurance, who were being denied insurance, for people in prisons. And then really the issue of access to treatment became the focus, because government had said, we know there's new treatment available. We know that it's possible to prevent the transmission of HIV from mother to child during pregnancy and birth, but it's too expensive. We can't possibly be asked. We're a new democracy. We can't possibly be asked to buy these meds. And so Section 27, well, AIDS Law Project at the time, representing the Treatment Action Campaign, litigated against the pharmaceutical companies to stop the profiteering from ill health, from HIV. And that litigation led to a settlement where the pharmaceutical companies agreed to provide free prevention of mother transmission anti-retrovirals. So we'd won. It seemed like the barrier had been removed.
But then and that was in 2002, right? That case.
Exactly.
Where
that was.
Yeah, I mean, it was several years in the making, right? But in 2002, you obtained...
It was many years.
That concession where basically they said, okay, we don't need to charge you outrageous prices. It's a one-time injection, was it? During labor, so to prevent birthing mothers from transmitting HIV to the newborn, which was then... the transmission rate was quite high, right?
The transmission rate was very high, and really what prevention of mother-to-child transmission does is it prevents mother-to-child transmission, but it also takes care of the health of the woman. So it starts to manage the HIV in the pregnant woman herself. And if she then continues with treatment, we now know that people can live as long and as healthy lives as anyone not living with HIV. So it's a fundamentally important intervention to assist women and to prevent transmission to their babies. But it turned out that the problem wasn't just the profiteering of the pharmaceutical companies. Of course, it was also the profiteering of the pharmaceutical companies. The problem was that the then president and the then Minister of Health had adopted this theory that was being peddled by quacks, that actually HIV doesn't cause AIDS, and that the treatment for HIV in itself is dangerous. And so government said, we're not going to roll out treatment, and we're not going to roll out prevention of mother-to-child transmission. And so then we realized that there was another barrier, and that was that government was unprepared to save people's lives. And so in all this time, the Treatment Action Campaign had been working with people living with HIV, doing HIV and treatment literacy, so that there was a very empowered group of people living with HIV who understood what HIV did to their bodies, who understood what AIDS actually meant at a cellular level, and who understood what treatment would mean. And so together with the lawyers was this extremely strong movement of people living with HIV who were ready to fight. And those people living with HIV, the doctors, the scientists, the activists, and the lawyers came together to work on first advocacy and then litigation to force government to provide the prevention of mother-to-child transmission through an anti-retroviral. And we were successful in that case. And it's led to the rollout of now what is the biggest ARV program in the world in South Africa. So that was our early days as the AIDS Law Project, becoming Section 27 in 2010.
Wow, that's fantastic. And it really helped curb the transmission of HIV and prolong life expectancy, right? Because I was reading statistics that before mother-to-child transmission was offered to pregnant women, 27% of women would, on average, transmit the virus to the newborn. And since then, it's almost negligible. Like, it's so preventable that it was really, criminal not to offer it to women. But also, as you said, it then put them into the pipeline for anti-retrovirals from themselves. And that, was the beginning of the treatment of people with HIV that allowed to reduce this. Because once you're under ARVs, I don't know if my listeners know this, if you're under treatment, you become non-infectious, basically. You can suppress the virus effectively such that you don't transmit it to others. So that's incredibly important. I mean, that was exhilarating at the time, I'm sure. Those kinds of victories, forcing the government, despite their denial campaigns and all that, to actually meet their obligations. And they did comply, right?
They did. And we've, as I say, we've seen this rollout of treatment that has been obviously extremely beneficial for people living with HIV, but has also had knock-on effects for the health system, because a health system that requires there to be a rollout of daily treatment to a large number of people has to operate fairly efficiently. And we have some serious problems in our health system, which we can talk about, but the HIV treatment program has really driven some of the strength of the South African health system, and has also driven a lot of science related to HIV, which has benefited people all over the world with improvements in the treatment available.
Wow, yeah. And I mean, it's interesting that it began with an issue that touched on women and children, because, of course, the famous podcast is interested in the situation of women in particular. And I thought that was interesting that that's how that came about. And maybe that's not surprising, because one of the initial focus of HIV treatment and prevention was the question of pregnant women. I mean, that's how many women were diagnosed, because they were pregnant and then they were tested, right? And that's how they came into the system. But it's interesting how HIV was, in a way, a women's issue early on in South Africa.
Yeah. And I think women's health is often such a test case and a touchstone for a health system, because women do access the health system more than men.
Yeah.
And that's because of good health-seeking behavior that we generally see amongst women, better health-seeking behavior than for men, but also because of having children, there's a need to access the health system. And so it really has, it's pushed our treatment system, it's pushed our health system, and it also means, and I think this is important for the current day, it means that when health systems are struggling or when they're under-resourced, it affects women more.
Yeah.
And that is our concern now, because we have health systems that are not strong, that in many cases are directly disadvantaging women, when the health system can actually do the opposite. It can facilitate gender equity, and what we see often, unfortunately, is the opposite of that.
Can you tell me then how Section 27, moved from being called the AIDS Law Project, which was really focused on HIV, into Section 27, which is one of the articles of the South African Constitution that provides for the right to health, including reproductive health. But in fact, you've moved into a series of socioeconomic rights, I believe. So tell me, what motivated that? Why the broader focus?
Yeah, well, I think as the 2000s were unfolding, AIDS Law Project's work had been focused directly on HIV, but really started to broaden. It started to broaden into the health system that is needed for people living with HIV to be able to access treatment,
Right.
the health system that's needed to prevent HIV from being transmitted. And so we started looking into broader health systems questions, and then importantly into socioeconomic determinants of health, or social determinants of health. And those include access to water, access to food, and importantly, access to education. And so in 2010, we decided to change our name from the AIDS Law Project to Section 27 to recognize that we are moving beyond working only on HIV, although we still do work a lot on HIV, into these broader questions. And of course, it also gives us an opportunity when we say what our name is, and people say, what a strange name, what does that mean? We can do some constitutional literacy and say Section 27 is the right to access healthcare services, food, water, and social security. So we now work on health, we work on basic education, and we work on these intersecting areas, including climate justice, including gender justice, and including the right to food.
That's incredible. And it's so basic, like even when you just deal with HIV, that you can't really take those medications if you don't have food, right? Because they're so harsh on the stomach. And if you're not housed, like if you don't have anywhere to live, it's very hard to have a life stable enough to be able to take your medication and show up for your appointments, etc. So yes, of course, it's all connected, isn't it? Like you can't just,
It is.
These vertical programs where you drop just an intervention don't make sense. Now, can you tell me a bit, because I was looking at some of and we talked, a few weeks ago about some of the work you've been doing on issues of reproductive health in particular, since that's part of Section 27, the text of the Constitution. What are some of the issues? Because the right to abortion is guaranteed in South African law. Bravo, due to the work of feminists at the time the Constitution was written, there was a real push for these rights to be enshrined in various laws and in the Constitution. So tell me how you've taken up that mantle to ensure access to abortion rights, for example.
Yeah, so as you say, Section 27 does a lot of work on access to abortion. And again, this is based, as I said, on the right to reproductive healthcare services. And then, as you mentioned, one of the early pieces of legislation in South Africa was the Choice on Termination of Pregnancy Act. The Constitution, the final Constitution, is a 1996 document. So we had an interim constitution in the period where we moved from apartheid to democracy. And then 1996 was the Constitution. And also in 1996 was the Choice on Termination of Pregnancy Act. And that was a very carefully thought through strategy by feminists at the time to make sure that these rights are concretized in a piece of legislation. So it came out before even the National Health Act, which I think is really interesting, which deals with the rest of health. So we have this permissive legislative regime that provides for access to abortion up to the 20th week of pregnancy, and in different circumstances, depending on whether it's up to 12 weeks or up to the 20th week. But really, it is quite a permissive program. It's supposed to be free. Access to abortion is supposed to be free in the public sector. But despite what the law says, it can be really difficult for women to access abortion and to access it for free in the public sector. And so we assist a lot of women who have been denied abortions, and they get denied abortions for a variety of reasons. Often they get told when they go to the clinic that this particular clinic doesn't provide access to abortion. And that can be because the clinic hasn't been designated or because the abortion provider isn't there today, but often there's no referral to another facility that can actually provide the service. There have been various problems with stockouts of the medication required for medical abortions. And then importantly, there is a lack of regulation of objection, of abortion denial. And so while there's an attempt to balance the religious and cultural beliefs of healthcare workers and the right of women to access an abortion, in reality, the religious and cultural beliefs seem to trump the right of women to access abortion, which is often the case all over the world. And so women will often be turned away from first trimester abortions. And then when it comes to second trimester abortions, it is much, much more difficult to access. We will often have, in a province, for example, of 7 million people, so about 3.5 million women, there are 2 facilities that provide second trimester abortion, and they'll provide to 4 women a week. And so it's really well nigh impossible to access abortion in some places across the country. And so we work with women women who have been turned away to make sure that they can be in touch with a provider that will actually be able to provide the service. And often that's enough. Often getting the woman who's seeking the service in touch with a hospital or a clinic that's able to provide is sufficient, but not always. And last year we had a case of a 16-year-old girl who'd been in a relationship with a much older man. She fell pregnant and she didn't want to have a child. She was denied access to her first trimester abortion when she went to the clinic for various nonsense reasons. She was then scared off seeking further care, because that's what happens often when you get denied by a government service. You're scared. And this is a 16-year-old girl, let us remember. And by the time she came to us, she was in her 20th week of pregnancy. Now, the second trimester abortion providers, although they're supposed to provide abortions up to the 20th week, said no, 20th week means 19 weeks and 6 days, and that's the cutoff point, and we refused to provide. So we had to litigate, went to court on an urgent basis over a weekend, in fact, and argued and were successful in arguing that the 20th week means 20 weeks and 6 days. And if somebody complies with the other requirements to access an abortion, they must be able to access it up to 20 weeks and 6 days. And she was able to access that abortion. The court ruled in our favor. She was able to access the abortion, and she was able to return to school.
Wow.
So that's some of the work that really we shouldn't have to litigate on, and yet we do. And there are, that case is now a precedent for other women who need to access later term abortions. But there are also, as I say, various systemic problems with there being insufficient service providers within the facilities, with there being stockouts of medications, with insufficient facilities being designated to provide the abortions. And these are the kinds of things we need to work on, so that not every woman needs to reach us in order to access the services to which she's constitutionally entitled.
Right. And are women turning then to informal sources of abortion pills as a result? I would assume there's,
Yes.
lots of that going on if it's so difficult to access it in the system.
And it's of course, as we all know, incredibly dangerous. You have on street poles around Johannesburg, the city where I live, abortion one-day pills written on the street poles. And these are not medical providers. These are people who are selling all sorts of things. And it puts women and girls in a very, very vulnerable position. And they often then, due to incomplete abortions or other complications, have to access care on an emergency basis, which puts their health and their lives at great risk. And so it's important that, given that we have this legislative and constitutional provision, at least in theory, that the government takes the steps to both prevent access to unsafe abortion and to secure access to safe abortion for anyone who needs it.
Right. Because, all these scammers will just extort these young girls. They'll give them sugar pills or whatever. And yes.
Or much more dangerous
stuff,
medication. And that is what we often see.
Is there better news on access to contraception, since there's these, as you say, cultural religious resistance to abortion? Is it better on the contraceptive front?
It's better, but it's still not where it should be. So we work with partners in a grouping called the Stop Stockouts Project, where we monitor stockouts of medication. And when we started the Stop Stockouts Project back in 2013, there were big problems with anti-retrovirals, so HIV medication, tuberculosis medication, really a range of medication being out of stock. As a result of this ongoing monitoring and reporting and escalating, government has established its own monitoring mechanisms that have allowed it to improve the supply chain. And so we now have much better access to medication. But what we have been finding is that in the last 5 years, the most out of stock medication is contraceptives. And so we have this situation where women are firstly, in schools aren't being given the kind of comprehensive sexuality education that they should be being provided with,
Right.
girls and boys. And Section 27 does a lot of work on that as well. They then struggle to access contraception at facilities, and particularly if you're a young girl in school uniform, the nurses are often unwilling to provide you with contraception if it's in fact available in the facilities, and then it's difficult to access an abortion. So at every opportunity where we could be assisting women to claim power over their own lives, we are putting an obstacle in their way, and that's something that Section 27 is trying to fight.
And is there, I mean, anyone doing education of health providers and those nurses and that intake personnel that, turns away these young girls? Because obviously this needs to change. You can't just have this judgmental behavior continue.
Absolutely.
No?
I mean, it needs to come at the point of their training.
Yeah.
And there are organizations, and we've worked on some healthcare worker advocacy work and rights literacy for healthcare workers. We've done some of that work. And then in facility as well, that kind of information exchange, I think, is really important. And it links actually to another case that we worked on fairly recently, which was about access to healthcare services for pregnant women and lactating women and children under 6. Because while the National Health Act says that all pregnant and lactating women and young children are entitled to free healthcare services in clinics and hospitals, there was a provincial policy that limited that right to only citizens. And so it meant that people who are not from South Africa, refugees, asylum seekers, undocumented people, were being turned away from accessing those services. And so we challenged that policy and were successful. And as a result of that, not only is there an order that says that anyone, regardless of their citizenship or documentation status, is entitled, if they're pregnant or lactating or a young child, to access these healthcare services, but also there must be a circular that goes from the Department of Health to each hospital to tell healthcare workers what their obligations are in relation to this group of people. And there must be posters on the walls of each hospital to tell patients what they're entitled to. Because what we saw, and those are things we asked for in the court order, what we saw is that a court can decide whatever, but if the health workers haven't been told what their obligations are, and if patients aren't empowered with the knowledge to be able to fight for their rights, nothing is going to change. And so we incorporated that quite sort of creative and unusual element into the court order to make sure that it actually makes a difference in the lives of people.
Yeah, right, because the Constitution says everyone is entitled to this health care. So everyone is not just citizens, right?
Everyone is everyone.
It had to be fleshed out, and how, that's fantastic. One of the issues that I think is really interesting, one of your strategies is using grassroots mobilization, right? And that's been true since almost the beginning of the work of Section 27, that when the court was considering access to mother-to-child transmission of prevention of mother-to-child transmission of HIV, there were lots of grassroots HIV groups, the Treatment Action Campaign, mobilize around the courthouse and doing kind of vigils, right, to remind the court that this, influenced real people. So you tell me a bit more about that. Is that something you've continued to do, to really work closely with grassroots groups? Because it can be easy, I think, I'm a lawyer myself, for lawyers to just do their thing, in the courts and not really connect to civil society. So how does that work for you all?
It's a very important element of the work that we do, and that's for a number of reasons. Firstly, we need to make sure that as human rights lawyers, our work is driven by the people we're trying to serve. If what we're doing is not a priority to the people who are going to be affected, then we should be doing something different. And so we try and make sure that we are always prioritizing the priorities of the people we are trying to serve. So that's the first thing. The second is that we saw through the early cases with the treatment action campaign, the prevention of mother-to-child transmission case, other cases on access to treatment, just how important it was for the affected people to understand and to support and to live the fight. Because without that entrenchment in the strategy, whether that's advocacy strategy or litigation strategy, it was much less meaningful to the people who are affected. And then, as you say, much less persuasive for the general public and indeed for the judiciary, who we pretend are completely separate, but are also humans and can see what's going on. So for us, our closest ally remains the Treatment Action Campaign. We work with them as an organization all the time. They're a big organization working across the country. And so they are often our client. But we also work with other patient groups like the Cancer Alliance on access to cancer treatment, the People's Health Movement, and many others who are patient groups who focus on whether it's mental health care services, HIV, cancer, women's health, etc. And then I think another important element is the communications of the work, because people, not everyone is impacted by every issue, but it's important that everyone understands what is happening and can hopefully support the kind of campaigns that we're running. And so we try and do rights literacy, not only with the particular groups we're working with, but also with everyone in South Africa who may be listening to a community radio station where we can come on and talk about gender-based violence that's directed at children, and what you can do as a parent and what a child can do if they are a survivor of gender-based violence, for example, and what accountability measures are needed. So that kind of communication through the media, through submissions, through other forms of creative communication is really important to ensure that the country is buying into this project of social justice and the pursuit of social justice.
You know, I was in the Gambia in West Africa last month, and they're going to the Supreme Court. They're being taken to the Supreme Court by the far right, which wants to eliminate the ban on female genital mutilation in the law. And so it's going to the Supreme Court, and the lawyers were writing the briefs, and they were wondering, they're like, I don't know if we should have, you know, some of the feminist groups want to be around the courthouse and do, you know, some protesting or some marching or some speaking. And we don't know if it's a good idea. Maybe it's going to look bad or indispose the court. And I was thinking of the case of South Africa, and I said to them, well, I think it might actually be beneficial. I mean, you know, if you had to speak to the Gambian activists and lawyers, would you say, yes, do it, you know, do show up? Yeah.
Without a doubt, without a doubt. It's so important for both sides. It's important for the people who are affected to be able to express themselves in a way that makes sense to them. And often the words of lawyers and briefings and clever submissions are not the words that make sense to most people. So I think that display of activism is really important. But as I've said, it's also important to show the judges and the journalists and the average Gambian citizen that actually this is important, and that there are real people behind these legal arguments. So it's not as easy in every country to protest, and we've also got to recognize that, and many other countries in Africa are unable, and elsewhere in the world, are unable to be involved in the same kind of protest and activism as we are very fortunately able to be involved with. And I suppose that's part of why we need global solidarity. We need to be able to learn from each other and lean on each other. But if you are able to stand up in support of litigation and say, our experience suggests that it can be very powerful.
Yeah, that's... So I'll relay that to them and say, South Africans say, do it, but do it in a way that makes sense in the Gambia, but do it. Yeah, do mobilize.
Exactly.
Now, one last question, which is the cuts by the United States to development assistance in healthcare and education and in, a range of issues, humanitarian assistance, food. I mean, they've cut so many things. How, and I know they've targeted particularly South Africa. Donald Trump has a beef, in his own mind with South Africa, in addition to wanting to resettle white South Africans to the US. Kind of unimaginable, but it is real. And so how has that affected the health sector in South Africa, the education sector, and how is the government responding to this attack?
So the first thing I should say is that there are other countries that have been much harder hit than South Africa, countries whose whole HIV program was funded by USAID and PEPFAR. So there are countries in real crisis. South Africa has been pretty hard hit, however. 17% of our HIV program was funded through USAID.
Wow.
So there's been a dramatic impact. There's been a big impact on our closest partner, the Treatment Action Campaign, who was receiving funding from PEPFAR for a community-led monitoring program, an incredible program that monitored 400 health facilities across the country to see what's actually happening, a really important part of a functional system. And that funding all got cut. So there has been that dramatic impact, and early evidence is suggesting that the real impact on the ground is varied. We're seeing a decrease in testing, in HIV testing rates, which is a problem. It's an important part of HIV program to get people to test. Really worryingly, there's been a decrease in viral load testing. And as you say, if a person is on anti-retrovirals, their viral load, so the amount of HIV essentially they have in them, will decrease. And once that happens, once your viral load gets undetectable, you're unable to transmit HIV. So it's a very, very important HIV prevention and HIV control mechanism. And that testing's going down. We're also seeing people like sex workers and men who have sex with men who previously had their own clinics that would provide the kind of treatment that they needed without stigma and discrimination. Those clinics have closed, and so they have been told to go back to the clinics that stigmatize them and discriminate against them. And often their files have not been transferred, and the treatment that they need hasn't been provided at those facilities. So it's meaning for individuals. They are having a much more difficult time getting the care that they need. We're also seeing increases in stockouts of ARVs and of contraceptives. So the direct HIV treatment impact has been fairly significant. The other worrying thing is that it's not just the US that's cut funding. Because of what's happening in the Trump administration, European donors are also moving their money out of foreign aid and towards militarization. They're moving towards supporting their militaries with a view to being able to defend themselves if they need to. And so we've seen not just US funding leaving the country, but also other funding. And we're not seeing government respond quickly enough. So there have been some moves to try and mitigate some of the losses, but nothing that's really filling the gap, and nothing that's convincing people that the government really has a plan. So as part of various civil society groupings, we've been doing a lot of work trying to push government to do what it needs to do to keep everyone in South Africa safe. There aren't other donors that can step into the fray. It was just too much money. So donors are trying. There are various steps that have been taken, but they're not really able to fill that gap. And so we're seeing really a period of reorientation, trying to work out how we do the HIV program, how we do human rights work in an era of great global instability that everybody's having to deal with, but also significantly less resources, and that makes it quite a difficult time. But we have a resilient civil society, we have strong human rights activists, we have a strong constitution, we've been through a lot as a country, and so we're fighting, we're doing as much as we can to ensure that this constitution means something. that it really improves lives, and that we start moving towards the vision of the Constitution, which is an equitable and socially just country.
Yes, and yeah, in closing, what you're saying is very true. People often assume that private donors, private foundations like the Gates Foundation can come in and take over, but they don't have the same the resources that governments have. It's orders of magnitude. It just cannot be, the gap cannot be filled by private donors. That's the hard reality. Yeah, 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 yeah.
Yeah, it is, and particularly when there are other governments who are also running scared, and when there are other instability risks in the world, it just means that we're in a pretty difficult time in South Africa, as in many other places in the world.
Well, I'm sorry to hear that, but I'm also really glad you're there, you and your fantastic team of lawyers and activists and community mobilizers, researchers also. I hope this energizes people to support Section 27 in its work. And also, I just want to thank you today for, spurring the imagination that, yes, we could have health and education as human rights. We could write that into law, into constitution. We can think in those terms where everyone has access to this critical life-saving information and those critical services. It doesn't have to be a privilege. It should be a right. So thank you.
Yes.
Thank you, South Africa, and thank you, Sasha, and thank you, Section 27, and all the best to you. A luta continua. Let's keep up the fight. Take care. Bye-bye.